My name is April Wilson, and I'm here today to talk to you about the power of data, specifically how to use analytics to help reduce denials. So, without further ado, let's jump right into it. My name is April Wilson. I am the Vice President of Product Management here at FinThrive, and specifically, I'm over the Insurance Discover solution, but I have a grand passion for analytics and for using data to make better business decisions, which is why I'm thrilled to be able to have this time with you today to talk about solving one of the biggest problems right now in healthcare, which is claims denials, and what are some of the things that you can do to help make it better. So let's give a little bit of the industry background first. So there's an immense amount of loss, billions and billions of dollars. As you can see on this slide, it's over $262 billion as of the time this particular study was performed. However, I'm sure it's closer to $300 billion right now. And really, of that, $24 billion were initially denied. A lot of denied claims can be recovered, but it's very important to have the right things in place to help set your strategy. And on average, it's expensive to try to solve this particular problem, at least with manual effort. Without technology in place, on average, we estimate it's about $118 to recoup a denied claim, just with a person picking up the phone, calling the payer, trying to negotiate and get that claim resubmitted. So it's a huge problem. Not only do we not get our initial money up front, but we also have to battle insurance companies and potentially not get any money at all in an environment where we know that payers and providers do want to get closer. So how do we help solve that particular problem? We don't want to go into a legal situation because legal battles definitely cost a lot of money. And in addition, they're slow. They don't necessarily get resolved quickly. And you have to focus on what is the end experience to the patient going to be. It's probably not going to be a good one. And sometimes losing the money outweighs all of the time and effort and expense that you might have to fight a denied claim. So what can you do to help prevent yourself from being in a lose-lose situation? Before we go there, it's important to take a step back and understand, how do denials even occur in the first place? Because this isn't a new problem that we're experiencing. It's something that's been going on for quite some time, although it might qualitatively feel like it's gotten worse in the last few years, particularly pre-COVID was, I think, when we started to really see the tsunami of claims denials coming through, and we look to technology to help solve those problems. But let's talk about how it happens in the first place. So one of the biggest reasons, and this is rank ordered based on the amount of experience that we have in the space, a lot of the times most payers require an authorization for specific services prior to the patient's visit. So if that pre-auth is not given in time, the claim is probably going to be denied. Also, payers update their rules every single year. So you might be working on the assumption that a certain service or benefit was provided by the payer last year, so surely it's going to be available this year for submitting that claim, but the rules have changed, and so you're working with outdated information, and that's why the claim was denied. In addition, it's not unusual for hospitals and healthcare providers to pick up additional payers to service their local communities. It's a pretty big space out there, and it's not unusual for us to experience multiple payers emerging into the space. And so we might not have a pre-auth for a particular service that's being performed because it's our first time working with this payer, and we don't necessarily know that that's the situation. And then finally, staffing is a big concern. You might not have the folks to make those phone calls and make sure that authorization is obtained prior to the patient coming in to receive that service. This is probably I won't say it's a new problem, but it's definitely a problem that we've seen more and more, particularly this year in 2023. Staffing is a major issue for hospitals and providers. So without the ability necessarily to find the talent that you need to hire up and fill those vacancies, what can you do? In addition, let's talk about some of the eligibility reasons why that claim might be denied. So a patient might have insurance coverage. However, the service that they're having performed during their encounter is not a benefit that's covered by the insurance provider. Therefore, the claim is denied because it's just not covered. One of the biggest reasons that we see, and this is, you're going to hit a passion point for me, is the fact that there are just validation errors. Sometimes people just fat finger it at registration, or patients, when they're filling out their own information online before their visit, sometimes just typo their own date of birth. They've typoed their address or they've typoed their name. When any of that demographic information does not quite sync up with what's in the payer health system, that claim can get denied because we don't know with 100% confidence that it is that particular patient's benefits that are being used. So it gets denied because there's ambiguity when it comes to the demographic information. There's no verification that the patient even had insurance prior to the visit, or that that benefit existed for the service that was provided. So this comes back to the staffing issue, that there's just not folks to go ahead and do all of those checks before the patient is in at the time of service. Medical necessity is also a major reason that claims get denied. So a payer's plan might not cover that particular service, or they might not deem that service or encounter to be medically necessary, and therefore that claim gets denied. And in a medical necessity situation, if the plan does not deem whatever was performed to be medically necessary, it will be denied. The patient's stay may exceed the number of allowed days for a service. Each payer has different rules for exactly what will be covered and for how long. So while the initial stay may be covered, the later stay may not be, which is why we get into a claims denial situation. And are there resources being used throughout that encounter that an insurance company might not necessarily think are warranted? So it's important to make sure that every part of that particular claim is error-free to the best of your ability. For example, you might have put in a CPT code that involves parts of the procedure that may not be considered medically necessary. So, for example, an MRI might be approved, but an MRI with contrast may not. There's subtle differences within every payer's plan allowances that can cause the claim to be denied. From a validation perspective, again, a lot of it might just be inaccurate inpatient criteria. Maybe they were admitted, but the payer plan does not necessarily think that that service requires an admission. There might be an untimely length of care, inappropriate use of staff resources, or the treatment may not match the diagnosis code that was entered as part of that claim. There might be invalid or missing claims data that doesn't pass a payer's adjudication efforts and edits. So it's important to understand why denials happen and make sure that you've got processes, systems, and technology in place to help really get around why is your particular provider system encountering as many denials as you are. So one of the most important metrics that we look at is, what is your denial rate? So if you submit 100 claims and 40 of them are denied, your denial rate would be 40%. It's important to benchmark where you are before you start any initiatives to improve your performance. That's one of the major power that data provides to you. Think about it like you're starting a diet. If you don't step on the scale to know exactly where you are right now, it's harder to make strategic adjustments to your diet and exercise regimen in order to help you meet your goals. In the world of claims denials, obviously you want that number to be as close to zero as possible. You want all of your claims to go through, and you don't want any of them to be denied. But it's important to understand where you are right now. So that's the first and most important benchmark for you to look at. The next thing to look at is your financial denial rate, which is a bit of a mouthful to say, but think about it this way. It's the amount that you're expecting to receive back from the payer if they short pay you or they don't pay you as much as you were expected to receive. That's more of a financial denial. You might have gotten partial claim payment, but maybe the payment in full did not come through. So you look at the denied expected payment amount divided by the expected payment amount. Maximum exposure lets you see exactly how much from all of your claims denials that you've received back could be recouped if you resubmitted the claim with a correction or adjustment on it. So we often look at the maximum exposure as well. And it's important to know where denials come from. Are there certain providers? Are there certain physicians? Are there certain service areas? Are there certain registration desks? Is it a new hire issue? If you have outsourced your revenue cycle or some of your intake, for example, is it your new vendor partner, for example, that is driving a significant portion of your denials? So it's important to understand exactly where the denials are coming from within your health system. And then it's also important to look at the denial rate based on the denial type. So we've talked about a lot of different denial reasons earlier in this particular presentation, pre-auth being a big one, medical necessity, invalid or incorrect patient information as it's sent to the payer for adjudication, for example. Those are really the top three. But there are other reasons why claims do get denied, and it's important to really understand what is my denial rate based on denial type. If you really want to get crazy with it, you can also look at by payer as well. There's lots of different ways to slice and dice your data in order to get the insight that you need to make different financial decisions or perhaps different contract negotiation, right? So if you happen to learn that you have a problem with a particular payer for a particular set of services, maybe when it comes time for you to renegotiate your contract with that particular payer, which is typically done annually, that's a conversation point in order to strengthen the relationship and improve the patient experience ultimately. So, understanding your denials, prior auth. Why are we not obtaining an authorization when one is needed? Is there, again, a specific team member, service area, physician that we know are leading to the problems? So, again, you're still looking at that key metric of denial rate, but you're filtering it by exactly where that patient might have been seen or what service that patient was having performed. And prior auths, we know, are expensive. That was cited as one of the most expensive administration tasks in a 2020 CAHQ report. If it's a staffing issue, you have two considerations to make, really. Consideration one is, can you staff up? Are there additional folks in your area or in the marketplace that you can hire to bring on board and help solve this problem? And if the answer to that is no, because we know that the demand for healthcare workers exceeds the supply at the moment, then you need to look to solve it with technology. What processes, what technologies can you put into place? I know that a lot of our clients, for example, are experimenting with robotic process automation, or RPA, otherwise known as bots, to automate and have machine learning or algorithms or AI do some of the work that a human being might have done. And we don't have a human being in the building because we have staffing issues. And then the last thing you need to look at is rules issues. So again, those payers, every year your contract is refreshed and their rules do change. So is your authorization rules engine being updated? And again, is that something that you're doing manually that perhaps you should work with a vendor partner to automate? Now let's drill down into eligibility. So why are we scheduling patients who are not eligible for services to receive care outside of those true self-pay patients? Is there, again, is it a training or staffing issue? Is there a bad process in place? Is there a person or group of people that aren't following best practices in terms of getting this particular patient scheduled? Is there not enough FTEs available to support eligibility checks? So that might be more of a conversation that you can have with your leadership to do a return on investment analysis. Is the cost of losing money for claims denials, does that cost exceed the cost of an FTE that might be available to work those accounts and get those claims put through correctly the first time so there aren't as many denials? It's a little bit of a business case scenario for you to consider. Again, the key metrics that you're looking at here would be your eligibility denial rate and your financial eligibility. Are you actually getting the amount that you expect to get back for that particular service and procedure? And that's a big deal. So it's important to understand maybe where your underpayments happen to be. And then finally, let's talk about the patient impact, right? Because everybody in healthcare, we do what we do to serve the patient ultimately. We do what we do because we believe that everybody deserves to live their best and healthiest life. So we've talked about it from an administrative perspective, and we've really focused on the revenue management side of things, but it does have a trickle down effect into the patient experience. Medical bills are a huge and terrifying problem for everybody, not just families. This slide happens to talk to families, but it is a known issue. And it's one that I've spent the last 10 years in healthcare working on. How do we help patients afford their healthcare? How do we get them to pay what they owe us for the services that we perform to give them a better quality of life? How do we have those financial discussions with patients up front, which is culturally a very challenging thing for us to do? And then just bringing it back to this particular topic, what does that have to do with denials? So let's talk about the landscape right now for patients. A lot of folks, 1 in 4, have an unpaid health care bill. 1 in 5 are trying to pay a balance they can't afford all at once down over time. And they may or may not be signed up for an appropriate payment plan with your organization. They might just be sending you random checks as much as they can, as often as they can, right? And we know that about 1 in 10 of them have a bill that they can't even pay at all. And this isn't necessarily new, but it is something that we didn't really see from a patient payment perspective until approximately 2016. And that's when we start to see patients really struggling to make ends meet, particularly when it comes to their healthcare expenses. And I think part of the reason is the fact that the average patient is not involved in the ecosystem of healthcare. They don't really feel like they have a voice. When we go to the polls for our elected representatives, for example, we're not voting on how our local hospitals are billing us. We're not voting on how payers reimburse the providers for our care. So a lot of the conversation is happening for consumers without even including the consumers in that conversation. However, we as healthcare professionals and providers really do care about the patients because we know if they have a great clinical experience, sometimes a poor financial experience will make them choose never to come back to our location. And we don't want that. We want patients to live their best, healthiest lives. And so until we've got everybody participating in the conversation, we've got the government involved like they are now, insurance companies involved like they are now, and hospitals and doctors involved like they are now, we've got to solve for that missing piece of having consumer household voices present. Additionally, we know that most health plans now exceed the resources for your out-of-pocket, your copay expense, or your deductible. Only 48% of Americans would be able to cover a hypothetical medical emergency of $400 without selling something or borrowing money. So think about what that really means. Like, how far would $400 take a patient in today's economy? And you can see for a standard physician office visit, maybe your annual physical, your annual physical under most plans would be provided, but routine care, maybe you're going in because you don't feel well, it's just a standard office visit. If your patient responsibility is approximately $400, which is the average out of pocket for a high deductible health plan today, they're fine. But any other kind of medical visit, they're going to wind up being underwater. A CT scan, for example, an average American would be about $428 underwater. An average ER visit, depending on their insurance plan, maybe $297 underwater, but maybe more, depending on how high their deductible happens to be and whether or not it's been met. For a vaginal delivery birth, for example, the average new mom is going to be about $2,700 underwater. For an appendectomy, $3,500 underwater. And hip replacement, $7,400 underwater. And this adds up. It adds up for both the patient health and the patient experience, but it also adds up in lost revenue for the hospitals and providers that, again, are passionate about keeping patients healthy. And then the last piece of it, and I can say this because in the last 10 years, I've probably done focus groups and one-on-one interviews with, I'd guess, around 10,000 patients or so in the last 10 years. So yeah, about an average of 1,000 patients a year. Sounds about right. The average American doesn't understand the healthcare system at all. They don't know how to reconcile an explanation of benefits, aka an EOB, with the actual bill that they've received from the hospital. They don't feel informed to basically help their provider look for errors on their statement or look for short pays perhaps from their insurance company or claims denials, right? All they know is they get a bill from the hospital and whoa, it's way bigger than they ever forecast it would be. And they're going to ignore it because they just assume that, hey, their insurance company hasn't paid yet. So they're just going to wait for the hospital to send them an updated bill. They don't understand that the fact that they got that bill, it's already been adjudicated. So that's part of the mystery surrounding healthcare for patients. Some of them don't believe it has any impact whatsoever on their credit score, or they don't think that they truly have to pay their bill because healthcare, they believe, is a basic human right. And then you've got other folks from a financial responsibility perspective that do want to pay their bill, that take great pride in paying what they owe for any service that they receive in their lives, but they can't pay it all at once. It's hard to find those financial options, financial assistance applications. If you're a not-for-profit hospital, how easy is your financial assistance policy to find? What is required for patients to receive discounted or free care? Do you have in-house payment plan options available? Do you have a partnership with a third-party financing company like Care Credit, for example, that could help patients pay their bills and also make sure that you are protecting the revenue that you should be receiving for performing those services? So it's a very complicated ecosystem, but the point is we get paid from payers far quicker than we get paid from patients. And to some extent, payers understand the landscape, they understand the game, and they understand the system. They built it, obviously. Patients, not so much. So I just touched on a couple of the reasons why they might just take that envelope and just set it aside. Or sometimes they don't even know that they're getting a digital statement. I've seen more and more providers switching to purely digital touch points now. And for some patient populations, it doesn't even occur to them to check their email for their bill, or if they get a text alert that their bill is ready and they can go onto the portal and look for it, again, a certain population isn't going to trust that. They're going to assume it's a scam. They're still waiting for that paper to come in the mail. And if you're a hospital that's moved to a paperless strategy, that could also be part of the reason that patients aren't paying you quickly. But to go back to what we were saying, if you can get your claims denials rate down, if you can make sure that you've corrected some of your processes or done some training if it's a people issue, or leverage technology if it's a staffing issue, if you can make sure that the bill that you're sending to the end patient is as low as possible, the odds are greater that they're going to pay you what they owe, and the odds are greater that they're going to have a higher satisfaction coming out of that experience than if those things were not necessarily present. So, again, let's go back and focus on some of the key metrics that are critical when it comes to understanding the denials landscape at your facility. So look for some of these common denial themes. Are there specific CPT codes that get denied over and over again, regardless of the payer? That's probably a training issue, or it could be more of a contract mapping issue. You don't have your authorization rules engine updated, and perhaps the contract has changed. Are there specific payers that we know to be a certain problem? That's something that you could send to your purchasing or your finance group for contract negotiation purposes in the upcoming year. Is there a provider that routinely has procedures denied? And this could be for a couple of reasons. It could be perhaps that they don't get the proper pre-auth ahead of time, or it could be that certain payers don't find something to be medically necessary that that provider does find to be medically necessary. And so, again, that's an opportunity to open up a dialogue between your facility and the provider that might be denying that particular claim? Are there partial payments that you're consistently getting from the same payer over and over again? AKA, do you have a problem payer, right? Which payer is your highest offender when it comes to denials? Which has the most financial impact due to denials, right? So if you have to prioritize or triage exactly how you're going to start to work down the mountain of denials that maybe you're sitting on top of, where do you start? If you know that you just work on improving either contract terms, rules, pre-auth procedures with a particular payer, is there one that's going to drive a higher financial benefit for your organization than any other? And then finally, are there employees or departments that are just constantly not obtaining eligibility prior to service? Is it a basic blocking and tackling issue? In this day and age, it's probably not, but it's always something that you want to look at and make sure that you cross off your list. And then if you don't have a denials analyzer tool in place at FinThrive, we're happy to help you with that. We certainly have a product to help you with it. I'm not going to go into a demo today, but I do want to make you aware that we do have that solution if it is something that you're interested in. But whether you buy it from us, whether you build it internally, or whether you go with somebody else, it's important to have a tool like that in place because you want to be able to have a quick and easy, at a glance, operational overview of exactly what's going on with your denials landscape right now, because that's going to help you quickly and easily identify cash flow disruptions. It's also important to see where you might have process or technology gaps behind the scenes. So if there's rules-driven categorization that is consistently wrong, which is leading to denials, then you know that you've got a contract mapping issue potentially. If denial ratios are stratified by zero or partial payments, you can see maybe who's consistently short paying you so that you can go in and resubmit that claim and make sure that you get every dollar that you're owed. It's important to have a granular view of code usage as well to discern payer behavior patterns with 835 responses that you might get back. And then finally, it's always important to have metrics that are transparent, easily digestible, easily understood by everybody in your organization so that if there's other ways to solve those problems, everybody in your organization that has a vested interest in improving the patient experience is sort of all looking at the same hymnal, if you will. We're all working off the same information. We can all see the successes and problems easily and quickly. And different groups may have a different view for why certain trends are happening. So if you put in a tool like the screen that I'm about to show you right now, our denials analyzer solution, that's great. I would recommend that you make it visible to folks at least throughout your entire executive leadership and perhaps senior leadership groups, right? Because we tend to look at data through the lens of our own particular silos. And so we may have hypotheses about why certain denials trends are happening based on our experience, but there could be, again, an independent group that isn't necessarily in your silo that could look at that exact same information and say, oh, you know what? I think I've got something configured wrong on the back end, and that's probably why they're seeing these trends. Let me see if I can get that taken care of. So transparency generally takes an organization from siloed to collaborative. Never underestimate the power of a dashboard is what I'm saying. So again, this is just a screenshot of that particular tool that we have. If you're interested in learning more about it, please contact your customer service representative or fill out a form on the page that got you here, and we'll get somebody to get you more information. From an IT solution perspective, outside of dashboards, there are lots of other solutions as well to help address this particular issue. So you can automate prior auth. There are several prior authorization technology solutions that are out there that may be worth looking into, particularly if you're having a staffing issue. The benefits of automating prior auth tasks are pretty obvious. Time savings, less lost revenue. Some cases we've even seen a 65% reduction in time spent on manual prior auth with a technology solution in place. So that's very important. Whether you're doing that with a bot or whether you're doing that with a rules engine, it's important to have something in place. It's also important to automate eligibility wherever you can. So use those 270, 271 messages that instantly check a patient's insurance status, or Global 270, 271, which can check multiple payers. Again, there's a lot of companies out there that provide automated eligibility checks. We are one of them, but if you don't want to go with us, we definitely recommend that you use one. In fact, of everything on this particular slide, eligibility automation is probably your top priority. And then in the third bucket, we've got automation of medical necessity, right? So we talked earlier in this session where you might have a particular provider who believes part of the services performed are medically necessary, but the payer consistently declines those because the payer doesn't feel like those add-ons are necessarily medically necessary. So if you find yourself in that particular situation, you may want to automate justification procedures to that payer about why those particular things are indeed medically necessary. And there's technology designed out there to help payers and providers collaborate better through the automation of medical necessity. So this would be the part of the presentation where normally I would take questions, but because we're recorded and we're not live, I'm going to imagine I don't receive any. But I hope that this was a very insightful and helpful presentation. I'm happy to meet with you one-on-one if you'd like to continue this discussion further. Otherwise, I'm sure there's somebody here at FinThrive that can absolutely help you out. I have enjoyed the time that we've spent together. I hope that it's been useful to you. My LinkedIn bio is there if you want to scan the QR code, connect with me on my network. I typically accept just about every single LinkedIn invitation I receive, whether it's for better or for worse. I always love connecting with people, particularly about the power of data. As you can tell, I just love it. So I'm going to go ahead and end the session, and it's been great talking to you today. Thank you so much for your time.